We have JS, 31-year-old female who is following up for subacute intermittent non-productive cough lasting more than a month. Patient has utilized over-the-counter Dayquil, NyQuil cough medication with no improvement. Cough is worse at night with chest discomfort. Patient complains of fatigue, brain fog, denies fever, environmental changes or travel. Past medical history, seasonal allergies, insomnia, GAD, vitamin D deficiency. The patient is on birth control, takes 1 tablet a day, Xanax 0.5 mg as needed, Buspar 150 once daily for GAD. Physical exam is normal, lungs are clear, no masses or asymmetry observed over the chest, skin is warm and dry, no nodule lymph node enlargement observed. Chest x-ray, PFT are normal. Labs are normal with elevation in CRP 19.2. Platelets are also getting elevated over the past few months. Last is 454. Differential diagnosis is non-asthmatic eosinophilic bronchitis. The cough is longer than a month and chest x-ray is negative. Patient has no to minimum response to bronchodilators. Another differential diagnosis could be GERD. Patient has negative PFT chest x-ray. The patient has chest discomfort and cough is worse at night, and she doesn't have any other signs and symptoms of GERD. It could also be pertussis since the patient has unremarkable physical exam. However, patient complained of fatigue. It is also less likely because WBCs are not elevated. Neoplasm couldn't be ignored as there is an elevation in platelet levels, but there is no evidence of weight loss, but patient does complain of fatigue and brain fog. Analysis, it is more likely eosinophilic bronchitis because of the chronicity and all the normal imaging. We can also consider GERD because of the symptoms and the patterns. For that, let's try a PPI for 4 weeks. Asthma is less likely. Patients' PFTs are normal, but we can also not ignore thrombocythemia or essential thrombocythemia, which is a rare condition that presents with same cough, fatigue, and elevated platelet levels. Plan is let's repeat our CBC and the CRP in 4 weeks. Consider hematology or oncology referral at that point. Pharmacological measures, let's do over-the-counter omeprazole for 4 weeks. Continue Zyrtec. Put her on a fluticasone and then Tessalon Pearl every 6 hours for cough. Ask the patient to stay hydrated, use a humidifier, do not eat any big large meals, especially late at night, avoid spicy food. Educate my patient for any red flags like sudden weight loss, coughing up blood. And the learning issues for me, I would like to explore more the essential thrombocythemia and autoimmune diseases. My question for the preceptor is, when would you like to, or if would you like to refer for oncology and at what point? Thank you so much.